This picture in 1 is difficult to put into a wording, but undoubtedly it is not a normal picture, this section here in figure 1. As chronic hepatitis renders a picture like in figure 2, this is very similar to the foregoing one. An acute liver failure with vessels remaining and parenchyma vanishing is in figure 3. Note especially the intestine and in here the duodenal bulb in figure 4, normally flat with some gas, as always behind, so to say, the pylorus. And here in figure 5 it is respiratory gliding as one of the motion phenomena in echographia. Repeated vomiting and dysphagia happened in figure 6. They were leading to the findings demonstrated. Acute swollen kidney and clinical signs of an acute pyelonephritis in figure 7. A harmless finding in figure 8 unless it is mistaken as a lymphoma. In figure 9, it is, as a not so seldom incidental finding in clinical echographia, to be seen what we find there, and this is understriking the need for complete abdominal scanning. This over 9 decades old organ in figure 10 shows marked parenchymal reduction, but still in normal function. An impressive finding in figure 11 needing urological support. This lady showed normal anatomy and function in figure 12. Lymph nodes in a prostate carcinoma blocking the ureter course in this figure. Another case of hydronephrosis in figure 14, 10 years after operation of an adenocarcinoma of the kidney. These late metastases in figure 15 had to be found. A sincere sign of portal hypertension is to be seen in figure 16. Do not forget the decisive click. As a sign of intra-abdominal abscesses, usually postoperatively, one finds, like in figure 17, gas influx into the liver. In static CT scanning, as a rule, misinterpreted as aerobilia. Only in sitting position such minor effusions as in figure 18 can be demonstrated, what brought us to routine scanning in elder patients when they are about to leave the stretcher. Unfortunately, a not so seldom finding as here in figure 19. A typically metastatic tumor of the terminal esophagus. In bubble technology, this tumor in figure 21 showed a vivid perfusion. Another esophageal melanoma is shown here in figure 22, in 22A in echoscopia, in 22B in endoscopia. In figure 23, it is the seldom finding of a liver brucelloma. Note the tip of the puncturing needle This huge tumor had to be found in figure 24, while in here, in figure 25, it was a huge hiatal hernia only. A dissection membrane of the aorta is to be found in figure 26, needing surveillance only. Again, and as demonstrated by figure 27, do not forget to do the adequate clicks. As a rare finding, varices of the esophagus were prominent enough in figure 28 to be visible transcutaneously. Level and reason of biliary congestion, as in figure 29, are easily understood. Effusion and pulmonary tumor are typical in figure 30. In figure 31, one finds a pulmonary tumor in bubble technology. Combination of erbilia and ileus are significant in figure. Easily overseen is this tumor in figure 33, which turned out to be a linitis plastica. This neurogenic tumor, liver metastasis, is in figure 34 shown. Fluid aspirated was rich in adrenaline. This tumor in figure 35 was found incidentally too. This spider net-like effusion in figure 36 is rather significant for a severe acute pancreatitis. This patient in figure 37 suffered from a cystic pancreatic malignancy of the head with duct dilatation. And in figure 38, typical sequela of a generous papillotomia, endoscopic papillotomy, can be noted. And in this case, in figure 39, obstructing with pseudocyst formation was caused by a malignancy as well. In this old lady in figure 40, a perforated ulceration caused this abscess. 10 years after having been considered stone-free after lysis and ESWL, this lady had asymptomatic recidive stones. Another advanced gastric cancer was found in figure 42. 25 years after B2 operation, this linitis plastica had to be found in figure 43. Amyloidosis caused here in figure 45. This caused here in figure 44. This is thickening of the walls. An intended liver puncture would be here in figure 45, a high-risk procedure, as we find a, so to say, suprahepatic bladder. Do not forget our region, as it is shown in figure 46. Note vascular architecture in these casts in normally and cirrhotic patients. In figure 48, note please heart beats in and disturbance of vascular architecture, as well as deconfiguration and decompensation. This finding in figure 49 is a unique selling point for us as compared to static imaging modalities and even autopsy. This is an invasive HCC in figure 50. Especially typical is portal tumor thrombosis. These conditions in figure 51 were treated successfully with ESWL. Results in the end in fashion of liver cirrhosis with all dynamic and study criteria in this figure. As well, a long-standing PSC with typical ball changes in figure 53 does result in a liver cirrhosis. This may even lead to the need of liver transplantation.